This is the third and final podcast in this series, where Stefanie talks to Lisa Carroll, midwife and IBCLC from the Rotunda, Fiona Carty, public health nurse IBCLC, and Rachel Conway, GP nurse and midwife and IBCLC. Here they're talking about antenatal care, dealing with inhibitions around breastfeeding, sharing feeding with partners, how to encourage women to breastfeed, and the use of formula top-ups, among much else. Enjoy.
Three, go.
Welcome to this section of the webinar. I'm Stefanie Preissner, and now we're going to talk to another three wonderful people about tips and tricks to support better breastfeeding. We will start with Lisa Carroll. Welcome, Lisa. Do you want to give us just a sentence or two about who you are for context for people watching?
Thanks, Stephanie. How are you doing? Yeah, I'm Lisa Carroll. I am clinical midwife specialist here in Rotunda Hospital. I have responsibility to support the women attending community midwifery team, and so the support I offer them is antenatal, intranatal on the ward, and then follow up with continuity of care in the home if indicated. I'm also responsible for care of women in the hospital who are not attending the community midwifery team.
Amazing. Let's start then, I guess, about antenatal challenges. We've heard from in other webinars about how we said, like, when would you have started your breastfeeding? When do you ask for help? And, you know, antenatally is actually, in my experience as well, the best time to start. Talk about what we can do antenatally.
Okay, thanks, Stephanie. Yeah, very important to be prepared for potential breastfeeding challenges. So the first thing you can do is attend to breastfeeding class. We've heard from Lelesh League, and we've heard the importance of linking in with the community groups. So we have Lelesh League, we have Friends of Breastfeeding, we have Kidu, we have Preparing for Life in Darndale, and we have Better Fingers. So all of these groups are more than happy to meet women in pregnancy to discuss challenges or even just to prepare them for a normal breastfeeding journey. However, for GPs and practice nurses to be able to recognise what issues may present a challenge for women, I'll just outline a few things that they might want to look at. So having a conversation with the women in their during their antenatal period is very important. So for GPs and practice nurses, you're having a look at what the woman presents with. Is she gestational diabetic? Has she hypothyroidism? Was this an IVF pregnancy? Then you're also looking at things like examining the breast. So asking the women to have a look at their own breasts. How do their breasts look to them? Do they have flat or inverted nipples? Do they have surgery? So breast reduction or breast augmentation can impact on supply going forward. Was there any breast changes in pregnancy? And then also to look at if this is a multip in a previous, with a previous breastfeeding journey. Did she have any difficulties? Or is she even stressed about the prospect of breastfeeding? So if they can say yes to any of these challenges, it would be prudent for the practice nurse or GP to refer this woman on to their hospital.
And then when they are referred, what has the Rotunda done to support those women who need more support? Okay,
so just under 2 years ago, the Rotunda launched a breastfeeding wraparound service. And what this is that women can either self-refer or they can be referred by the GP practice nurse. They can refer at booking or they can refer at any time during the antenatal period. They can do that by contacting us in lactation by phone or on our email, which is cmtbf@rotunda.ie. Or, as I said, they can have a referral by midwife. So what we've done is we have developed a package of care to meet these women antenatally at 37 weeks. We meet them at 37 weeks. We identify what the issue is. So say, for example, we took a recent situation where we had a woman who delivered during the COVID lockdowns. She had a difficult breastfeeding journey. She linked in with us and explained that she was very upset about how things went, that she didn't feel that there was any support there, and she needed to be prepared for for the birth of the baby. So we met her at 37 weeks, and here in Rotunda we have a chart. We have the MCMNS. So what we do is we went back into the woman's chart. We were able to look from the delivery. Was there anything that impacted on that struggle for that woman? So we were able to look at what was the mode of delivery. Was it cesarean section? Was it instrumental delivery? We were able to look at, was best practice followed? Did she have immediate uninterrupted skin to skin? Did she breastfeed within the first hour, or was she separated from her baby? So by looking at these things, we could then prepare this woman for the future. So we could say to her, okay, in the event that you have a cesarean section, here is best practice. So we put a little care package in place for the woman, and we document it on the chart, so that when the staff on the postnatal ward meet this woman, they realise, okay, straight away we know that this woman had previous breastfeeding challenges. We want to support this woman. The lactation midwife has seen her, and she has put a plan in place, and that plan is everything that we've already heard: skin to skin, breastfeeding within the first hour, being assisted to get a good deep latch, and watching that there is good milk transfer. So we prepare the woman, and as part of that package of care, we also, if she meets the criteria, we would introduce antenatal harvesting of colostrum. So the criteria for that is briefly that the baby is in a cephalic position, and that the woman has no maternal or fetal compromise. And if there's any concern about antenatal harvesting, it's a good idea for the woman to link in with her midwife or her doctor, just to be sure that she is suitable for antenatal harvesting. So then the whole package of care, we meet them antenatally, as I said, at 37 weeks. We introduce antenatal harvesting if it's safe to do so. We prepare the woman for the breastfeeding journey, and then we meet on the ward after delivery if it's indicated. We have found in Rotunda that we are preparing women so well that very few of them actually need lactation input on the ward, because they have the tools to cope. Postnatally then, they either discharge home with the community midwifery team, and if there's an indication, I will go out to their house and follow them up for up to 6 weeks, at which point then I will link them in with the community groups that I've already mentioned. Or if they're not getting their care from the community midwifery team, the Marina and Ger will invite the woman into the hospital as part of the breastfeeding support group. So
we may have more questions for that in the live Q&A afterwards. So I might just move you on. There's a lot. I think before I had breastfed, I didn't really know anyone who had breastfed. I'd never seen breastfeeding, and I think a lot of people, women, have a lot of shame because our bodies have been so sexualized that they're not comfortable getting their breasts out in public. What do you say to people who come up against these, like, I've heard it's awful, I don't want to get my breast, just that kind of like feminine shame that comes with our bodies?
Yeah. So firstly, Stefanie, to say that a lot of women are happy to breastfeed in public, and there is nowhere that you cannot breastfeed. You're going to breastfeed your baby on demand. You could be walking up the street, your baby needs to feed, you can sit down at a bus stop and feed. You can sit in Aldi on a sack of spuds and breastfeed. There is nowhere that you can't breastfeed to start with. But it is also good to acknowledge that some women are inhibited about breastfeeding, and we do need to give those women the tools to cope. So I suppose two things. If you are inhibited about breastfeeding in public, what you can do is be prepared, plan in advance. If you're going into town to have a cup of tea, plan where you're going to go. Is this shopping centre, for example, breastfeeding friendly? Do they have rooms for women to go and breastfeed? And if so, then the woman can go there and breastfeed privately. Also looking at clothing, you can have the one up, one down. So you're wearing 2 layers of clothing. If you do get caught off guard and you are in the middle of a shopping centre and you've nowhere to go, that you just have to breastfeed your baby, so you're going to wear your stringy under vest that you can pull down below the breast, and then you have your outer garment that you bring up, and then you can bring your baby in close and breastfeed discreetly. And I know that
I'll just interrupt you there to say that I'm actually wearing my breastfeeding. Are you wearing it? I'm not breastfeeding at the moment at all.
Okay.
I got this put into this hoodie so I could have easy access. And you
had the comfort of wearing the clothes that you like to wear, and it just facilitated your breastfeeding. Exactly. Brilliant. Ingenious.
What do we do when women want to share night feeds with their partner? And then after that question, I'm going to move on.
Okay, I'll try to be brief. The night feeds, so basically there's lots of other ways. So a lot of women say, but my partner wants to give a bottle or whatever. So there's lots of other ways that you can support. But if, and then that's in terms of, keeping guests at bay, helping with the food and the household task, and generally being supportive, because we all know that women breastfeed for longer when they have a supportive partner who tells them how wonderful they are for breastfeeding. Anyways, but leaving that aside, if a woman wants to be able to get a gap of sleep at night and the partner to give some breast milk to their baby, we have practical tips for that. So, maybe in the morning time, the woman can use a pump or a hacket to take advantage of that extra milk supply. They can store that milk in the fridge, and then we take, for example, a woman wants to breastfeed at 9 o'clock and then head off to bed. So to give her an opportunity to get a 4-hour gap of sleep, she can breastfeed her baby at 9 o'clock. The partner then can take responsibility for caring for the baby in the sick room. Mother goes off to bed. Baby wakes up, we'd say, for example, 10:30, 11 o'clock. Partner can give the bottle of formula at that stage. And then the next time that the baby wakes to be fed, partner brings the baby into the bedroom and mother wakes up. And that means she's had 4 hours from 9 o'clock to 1 o'clock to set her up to get through the night. And it also satisfies the partner's need to be able to participate in feeding.
Lisa Carroll, thank you so much. I'm sure people will have lots of questions for you in the Q&A. I'm going to move on now to Rachel Conway. Rachel, do you want to just give us a sentence about who you are for context, and then I'll get some questions to you?
Yeah, I am Rachel, and I'm a nurse, midwife and lactation consultant, and I'm working as a GP nurse now in Glasnevin, very happily, lovely hours. And I have 3 kids and always been really into breastfeeding. So when I did my nursing placement as a student in Holles Street, and I got to see what a lactation consultant was, that's what sparked the interest. And my mother was laughing. She breastfed all 4 of us. She was like, "That's gas, you're hilarious at 19. I want to be a lactation consultant." But it's really nice, really rewarding. So I do that as well as I teach antenatal classes and stuff, as well as the GP work. So that's me.
I know that there are many women out there who are afraid to start breastfeeding because they are afraid that when they want to stop, they'll be they'll be encouraged not to stop, and that they feel like once they start breastfeeding, they're not in control of their own bodies. So let's talk about communication with mum, being open to conversations about stopping breastfeeding.
Yeah, look, I think because this kind of podcast is very centered towards GPs, GP nurses, and how they're experts at communicating with their patients. I'm going to say patients, but you're meeting your GP and your GP nurse throughout your whole pregnancy, and they're the person you're entrusting, as you're growing your baby. So you kind of expect that you can chat openly with stuff like that. But I think all GPs are fairly open. When you're talking about goals and things like that, a lot of women will have different kind of goals. So you can kind of just meet the woman where she's at and just ask, like, what do you have a goal? If it's fine if you don't. But say the World Health Organization recommends that you breastfeed exclusively for 6 months, and after that you can start introducing solids, and then it's complementary foods up to 2 years and beyond. And just you can kind of mention that, that's an option, and for some women that would be what they want to do. And other women, they say, I'd like to just give colostrum, the first few feeds or 24 hours, whatever. That the important thing is that there's no kind of judgment there, that we're just saying, look, this is kind of the recommendation. How can we help you to support whatever your goal is? And you can be flexible. Your body is quite clever for when you're feeding your baby. It is supply and demand, and you can kind of stop and start when it suits you. Once you've established the breastfeeding, you can kind of get help with your breastfeeding team in the hospital or your local breastfeeding groups, and you can make it work for you. Like I would have clients who combination feed, who exclusively breastfeed until their child is 4, who maybe just ask me to help get the baby onto a bottle or whatever. So it's kind of whatever the woman's goal is. We just have to be supportive and open. But I think a lot of the GPs really know how to chat to them about that and find out what their kind of goals are.
And how do you tackle, or should you be tackling at all, people who come in with the mindset, it's just for me, I was bottle friended, I'm grand, it's my body, and I know that bottle-fed babies will sleep better anyway, and I want to get some sleep. How do you deal with kind of that generational trauma around breastfeeding?
It is. It's all to do with the old marketing, when like the Irish dairy industry is very strong. So, that kind of thing of like, oh, the bottle is just as good, your baby will sleep for longer. But actually, all newborns sleep for sort of 18 to 20 hours within 24. It's a pity it's not consecutive hours. It would be very handy for us, but they're all over the place. So that's normal. So a lot of the studies would show that because melatonin is released in the baby, especially at night and in the mother as well, like our sleeping pattern and our circadian rhythm changes a bit, but the babies don't have a circadian rhythm at the start. It has to develop. So you'll find that like all babies will wake a lot during the night to feed, and that's totally normal. You will hear of these kind of babies who sleep all through the night, but we actually want them to wake for their little tiny tummies to fill up and have a little feed during the night. So you could have a baby like, that you start from the start with formula and they end up, being a bit colicky or something, and then you've got a baby who needs to be settled all night anyway. So you don't know what you're going to get with your breast or bottle-fed baby, but just the sleeping pattern, the studies have shown that because the melatonin is released with that lovely fattier milk at night, a lot of women will have an okay sleeping pattern at night because they go straight into that deep sleep, and it syncs a bit with the baby's one. So it literally depends, but a lot of mothers will report like they have a better sleeping pattern at night. What was the first thing you asked me? Sorry. Oh yeah, the bottle feeding. Yeah, that's that's like everything. We see that a lot in GP with GP nursing as well. Like, oh, I have an auntie and she smoked until she was 106, and I did this and I did that. That's true. Like, you can have people with certain genetics and whatever, but we know that like the breast milk is biologically normal, and it's suitable and it's tailor-made for your child. So like the vast majority of babies, the breast milk from their mum will be suitable, but yeah, you can grow up and be absolutely fine. You're not going to know when a person is 20 what way they were fed if you ask them when they're in college, what were you fed. But it's just that kind of thing of like not just the health of the baby and the nutrition aspect, it's the antibodies that it gives for help fighting infection, lowering the risk of certain allergies and things like that. It's the fact that it's handy as well. But sorry, I'm getting a bit distracted here. But it's, what was the original thing that you asked about?
The main question is like, how do you should you be giving this evidence to mothers who say it's not for me? Or do you just sort of respect, like, okay, if you don't want to do it, you don't have to? Or should we be encouraging by giving this data to them?
Oh, sorry. Yeah. So, we definitely should be encouraging them and telling them the data, but just being open-minded. Like, the people do make their own kind of choices. We all know that, like, maybe we shouldn't eat sweets or we shouldn't do this, that, the other. But we're going to do what we're going to do. But just being, supportive and knowing, like, we're all, doing the best for our babies, giving them nourishment. But the added benefits of the breast milk, I suppose, a lot of people don't know about, is the things like the antibodies and things like that they might not really realize about. So it's good to kind of highlight that as well. So I think it's really important, in the antenatal period, the midwives will all be saying, oh, make sure you book your antenatal, your breastfeeding classes, and the GPs do that at the initial visit as well. Just really important. Book in, go and learn all about it before you start, because it's a lot less learning to do then after you have a baby and you're absolutely exhausted. And they'll explain all that in the classes to them, like the benefits of it, why it's good, and all the tips and the tricks, to kind of get them sorted. So when the baby comes out, you might have no issues, it might latch on just fine, but knowing all the different extra aspects can really help to kind of, you don't have to learn everything from the start, kind of. So just having all the info, and then you can make your informed decision a bit easier when the baby's, when the baby's there and you start.
Rachel, thank you so much. I'm going to move on to Fiona on that. Fiona, do you want to give us just a line or two about you and what you do so that we can have some context?
Yeah, so I'm Fiona Carty. I'm general nurse, a public health nurse. I'm IBCLC, and as of February this year, the HSE brought in a new role, new position. So I'm now working as a CNM2 infant feeding lactation specialist in the community. So I'm based in Dublin North Central, which is in CHO9, and there are 4 of us across CHO9.
Thank you so much for that introduction. So from my own experience as well, I had low supply, insufficient glandular tissue, and I breastfed inclusively. can we talk about formula and topping up your breast milk for women that have to, but also women who want to, who maybe don't have to?
Yeah. So in terms of the top-ups, I think it's important when GPs and GP nurses are seeing these mums that they establish what it is they want to do. So like that, if it's a decision that they want a combination feed, then that's fine, and just making sure that they're informed around their supply, and that by introducing formula that your supply can be impacted. If it's a case that the GP or GP nurse is seeing a baby that and is advising a formula top-up, I would assume the reason there would be generally that the baby isn't gaining weight. So what I would advise is that you need to look at everything. You need to look at the wet and dirty nappies, you need to look at the alertness. We also need to think about, are we weighing this baby too much? And that can have an impact. If we do too frequent weights, then we're not going to get an actual idea of how much weight gain, and this can cause increased anxiety for the parents. However, if all that is correct and we've decided that the GP or GP nurse has decided that the baby needs additional food and is recommending formula top-up, then you need to discuss with the mother at this stage, what is her goal and expectation? Like, is she happy to go down with the formula top-up? And fine, that's fine. But if not, and this isn't what her goal was, like, we need to find out, is there a reason why we have to give formula top-up? And can this be a short-term thing while we figure out what the problem is? So really this mum needs a full assessment. So like that, to see, is there insufficient glandular tissue? Was there a big blood loss? Was there delayed initiation of breastfeeding that has now impacted her supply? And can we do anything to improve that? So also need to talk about not going straight to, if the weight is down, to giving formula. Like, is it possible to express? Is that something that again, you need to find out, is that something that the mother wants to do? Does she want to express and give the top-up in the form of express breast milk? But really, if you're going down this road, I would advise referring back to the public health nurse to let them have a full assessment. A lot of our public health nurses in the community are highly skilled, very experienced, and like a good few of them are international board certified lactation consultants. All PHNs would utilise a BOAT tool, which is a breastfeeding observation assessment tool. I mean, if the GP or the GP nurse could observe a feed, that would be brilliant, but I totally appreciate that these mothers may be coming in for a range of issues and you've only got a short time to see them, and so you may not have the time to sit and watch a full feed, which could be 20-30 minutes, but even if you're able to have a look at a short feed and see, is there actually milk transferring, or if there's not, then why not? And again, what can we put in place to resolve this issue if we can? So like that, then the public health nurse will, if you can refer back to the public health nurse, will be able to do that assessment. And then if the public health nurse needs further support, then they will refer to us. So as I say, we're the infant feeding lactation specialists. That's what we do in the community. We will then carry out a full assessment and put a plan in place. That's the other thing. If you're advising formula top-up, like, mothers need to know, what is the plan here? Like, it's not really fair to send them off, top up 60 mils after every feed. Well, what then? And is that what is that it then? And also then, if you are going down the road of, well, you can give your express breast milk, you're entering into what's known as triple feeding, which is exhausting. It's not sustainable. So you don't want to just leave these mothers off without any further input or support. So really, these mothers need follow-up, like triple feeding. You're talking about breastfeeding, pumping, topping up. You're doing triple the job there, and as I say, it's not sustainable. So it needs to be a short-term thing, whereby there's a planned follow-up, and that's I think where either if the GPs or the GP nurses can follow up on that. If not, please link in with your public health nurse, who will and we'll refer on to ourselves, the infant feeding lactation specialists. The other thing about the formula top up is you're going to be removing that baby from the breast. They're going to be spending less time at the breast, so you're potentially further impacting the supply, and that's why then you would be advising to pump. But again, that all needs to be assessed, like has been discussed already, in terms of flange sizes and everything like that. So, and again, that's something that we can do as infant feeding lactation specialists. Yes, I think
great. We are running a little bit low on time, so I'm just going to ask you another 2 questions, and then we can get to other things in the Q&A. What do we do if a baby is throwing up, like all that precious milk throwing up before or during feeds or after feeds, or if they're just generally unsettled during or after a feed?
Yeah. So yeah, throwing up after you've spent all this time getting them on, it might have taken a while. They're now feeding and they take them off and they throw up. Soul destroying. However, what I would say is to remind the mothers that you see that when you spill something, it can look like a lot more than it actually is. So sometimes I'd advise them to spill like 10 mils of milk on a baby grow and actually see that it looks a lot. So it doesn't necessarily mean that they've thrown up their whole feed. I think here, again, what I'm going to say is observing a feed is what needs to happen here, because you need to look at the positioning at the breast. You need to look at the mother's supply and the letdown. So if a mother has very fast letdown, then the baby is going to struggle at that breast. It's going to be coming in very fast and they are more likely to spit up. And so utilising positioning is ideal. So if you can do the laid back breastfeeding, gravity will work in the baby's favour instead of against them and slow down that supply. It might mean the mothers might have to latch the baby on, let the letdown happen, take them off and just catch that initial letdown. And once that's passed, then the flow of the milk has slowed down and they can feed with a little bit more ease and comfort. And then in terms of getting frustrated at the breast, it kind of is could be potentially the opposite. So where the flow has slowed down and they're getting frustrated. And what's really useful here is watching, this has been discussed already, watching what the baby's doing at the breast. So the baby should be swallowing the milk at the breast. So you need to, we would say, listen for it. Often I find you can't hear it sometimes. So watching the jaw drop, you should see a deep jaw drop when a swallow happens. If that's not happening, advise the mother to do a breast compression, essentially like hand expressing, but while the baby's on, and see does that stimulate a swallow. After a few turns of doing that, and if it doesn't stimulate a swallow, then I would be advising to swap sides. And this might be why the baby is getting frustrated towards the end of the feed. And I find sometimes we hear mothers saying, oh, I've been told I have to leave the baby on for 20 minutes. That's not really the case, because a baby might feed really efficiently in 5 or 10 minutes. And then you're still there trying to get this baby to stay on for another 10 minutes when really we could be just switching sides and going, offering, see again, assessing what they're doing at the breast. Are they swallowing? Doing the breast compressions. If not, swap sides again. It's called what's known as switch nursing. So I would advise not to be looking at time, because you could have someone on for 40 minutes that's like, yeah, baby's feeding great for 40 minutes, but they're not actually transferring milk or doing anything in that time.
Great. I think we might leave it there and now open up for a Q&A so that people can ask you questions directly. Rachel, Fiona and Lisa, thank you so much for your time. I hope people listening and watching found that helpful. And we will go back to our panel now. Thank you.
Thanks, Steph.
Thanks, Stefanie.
Thank you, Stefanie.